when we need to highlight how important is this really is applying the principle or understanding the principles of evidence-based medicine. And also, how can evidence-based medicine fail us sometimes? So there is nothing always perfect. Without further delay, just to have an idea why this is important, we need to know how many papers being published every year. So if we are talking here about some statistics, you can see that per day that the biomedical, there is 5,000 per day articles published, midline almost 2,000 per day. And there is like 70 per day clinical trials or trials that published. And this is a big number that just simply telling you how many out there of piece of science is being produced. And imagine if every single paper of those need us to apply or changing the practice based on what's there, things will be just chaos. So here is the importance of applying the principles of evidence-based medicine and when to apply science at the bedside. I mean, we're almost as a clinician and the healthcare providers, so we need to be very careful on understanding this. Also, a recent Canadian survey showed that since 1665, there are 50 million published papers and almost 2.5 million per year. And you can imagine how much science is being produced over the years. So if we'll ask this question, I know this is difficult to make it like an interactive, but maybe by raising hands, sometimes I need to see the responses. So evidence-based medicine is a practicing medicine based on the best available evidence produced by a valid high quality research. So I need to know how many of you think this is true, this is false. We're still having time this evening, so that would be okay if people can just.
Through the chat, more Dr.
Yeah.
في chat, I don't see a chat function.
Okay, so yeah, if there is no chat, there is no point of. But anyways, I keep asking this question to trainees and my colleagues when we have lectures. A quite good number of people thinks this is a correct answer or true answer, but the reality, I will show it to you shortly. So if I have this question, patient with community-acquired pneumonia with respiratory failure, so middle age or whatever age, patient presented to the emergency department, fever, cough, hypoxic, failing the conventional oxygen therapy. He's clearly having a new patch of pneumonia in his chest or her chest. So how much do you think the evidence of starting some antibiotics, giving some respiratory support or ventilation support to this patient? I'm quite sure most of you, it goes without saying, and this is something that we know there's a strong evidence to support giving antibiotic to a pneumonia patient, and also if those patient is failing the conventional oxygen therapy, yes, we need to escalate the treatment and go for intubation, mechanical ventilation. But wait a minute, if I'll give you some further more information, and I tell you, you know what, this patient is a 95-year-old. He is bedridden for the last 8 years, diabetic, hypertensive, multiple old CVAs, advanced dementia, renal impairment, and also recently diagnosed with advanced pancreatic CA, diagnosed a few months, and also he's also for palliative. Are we still going to say, okay, intubating this patient, giving him the full support of mechanical ventilation would be a very strong, have a strong evidence and support for this decision? I'm sure all of you now start to rethink about this. So here we go. That's why evidence-based medicine is not only a scientific evidence, it's the collective assumption of clinical judgment, relative or relevant scientific evidence, and also very important to take in consideration the patient's values and preferences, like our patient that we have just discussed. So this is why evidence-based medicine is not a single piece of paper just published and we need to go ahead and apply this and this is very good. So we need to look at our patient values and preferences. Also, the clinical judgment has some rules here. Let's have another exercise and just to make things more clear here. If I tell you that anticoagulation for atrial fibrillation, we all know that we are anticoagulating patient who's developing atrial fibrillation and carry a risk of thromboembolism phenomena. So if I have 100 patients with atrial fibrillation, if I tell you with no anticoagulation, 12 out of those 100 will develop strokes. And this is, and 2 will develop 2 serious GI bleeds in 2 years. This is if I give nothing. But if I give the anticoagulation, I will have only 4 strokes. But in the other hand, I will have 4 major bleeds per 2 years. So there are 8 fewer strokes, but also there is 2 extra major bleeds. So how many of you will accept giving anticoagulation here based on this piece of information and this benefits? I'm quite sure, because we are not able to have some discussion here or interaction. Most of us will say, okay, I think this is very important. And yes, we need to decrease the risk of strokes. So we'll go ahead. This 2 bleeds is something acceptable and we can live with. But if I tell you, okay, if I tell you there is 4 strokes, but there are 6 major bleeds. Okay, so the risk now is higher. 8 major bleeds, 10 major bleeds. When I did this exercise many times and asked people, most of the physicians, at least, they asked them, when I reached the 10, they're starting to be afraid, and no many hands I can say supporting giving anticoagulation for atrial fibrillation, because they said, okay, there are 10 out of 100 major bleeds, is something really scary, which is completely understandable. But look at this. Actually, this is a real exercise being done before. And the blue is the physician response. The red is the patient response. And y-axis is the maximum number of acceptable excess bleeds. Or the y-axis is the physician and patient, number of physicians or patients. So look at the last one. Actually, patients are okay to accept up to 22 bleeds just to not live disabled. They are really, at least in this exercise, the people who participated in this, they wanted less strokes and they want to take the risk. While physicians are more conservative here and they're not exceeding like 5, 6, 7 major bleeds in order to accept this intervention. So this is something that personally make me think, okay, so our patients think differently. They don't. So, and this is very important when it comes to how we discuss interventions. Taking consent, for example. So we need to explain to them the risk, benefits, and if there is any alternatives intervention that might be. Why I'm saying this, because practically and sometimes people are giving this less attention, let me say. I personally, I noticed that patients, they like to hear numbers, percentage. So if we have some numbers that we need to give them, or we can tell them what is the chances of cure, what is the chances of complication, it becomes more understandable. And this example just can explain how patients think differently than physicians. So why we need to learn principles of evidence-based medicine is quite clear. There are a lot of benefits here. So we sometimes, or some people that might practice medicine by rote, by guessing work, by their variable experience. Here is a very important thing, which is to stop drug company which is the manufacturers. And we know this is a very carry a big conflict of interest sometimes, and still human is a human, we are part of this. So we need to be very careful when it comes to manufacturers' presentation, how do they sell their interventions, data. In order to argue and to understand, you have to be really or understanding very well the principles of evidence-based medicine, how those studies being conducted, what's the risk of bias and those kind of evidence. Of course, a drug company, they want to tell you how positive is their intervention and to convince you to start having this in your institute. So this is a very important thing, and especially for administrators and people who's stakeholders who's taking decisions in this subject. This is a very interesting piece of paper. Actually, I think it's 2017, published in the BMJ. And the payments by U.S. pharmaceutical and medical devices manufacturer to U.S. medical journal editors. This was a retrospective observational study, and it was really, for me, very interesting to see the numbers and the payment. Look at the last column on the right, the highest payment individual. For example, if we look at like cardiology down there, it's like $10 million being paid. Of course, this is being paid like sponsoring, funding research. It's not like direct payment, but it's still how much you think or we think this will influence decisions of publishing papers of in big journals. So here we are talking about some high impact factor journals. So something to keep in mind that human are human. So and to avoid being affected by this, the only way is to know how to read evidence and how to critique evidence. So you can tell individually if you are convinced to apply this to your patients or not, regardless of being published in the highest impact factor journal or not. Also, we know this, we have people coming to us and they're based on their own, efforts, they're trying to bring you some information about what you need to do as physician or healthcare providers. So also you have to be ready to answer those kind of discussions. Out of dated interventions and therapies, unless you are updated and you know what to, and there you have a very recent experience. You remember when the COVID pandemic started and hydroxychloroquine things, and everyone is talking that this is a drug and everyone is using, and it's almost a standard of care over the first few months of the pandemic. Everyone is giving patients the hydroxychloroquine. And later on, we found that it might be harmful. It's not only, it can help patients, but actually there's a huge systematic meta-analysis published, I think WHO or something, and it's harmful. So unless you're updated and you know what's going on day by day, you might miss or harm your patients. So how can we get the best evidence to support your practice? So we need to identify our problems, define a structural question, find the best evidence, how to validate this evidence, what are the results. And here I will take one exercise because I'm sure we have variety of audience, juniors and seniors. So we will talk about few points on critiquing articles, especially the interventions articles. But look at this statement. They're saying that in the 21st century clinician who cannot critically read a study is as unprepared as one who cannot take a blood pressure or examine the cardiovascular system. And this is very interesting, statement, because this is really important. We are taking our knowledge that impact our patient's care from the available evidence. So unless we are ready and we know how to read those kind of science, we will be in trouble. So level of evidence, I'm sure this is something most of you are familiar with, but we need to know that not every single piece of paper is something that even during guidelines development, we know there is a very weak evidence support that people should tell and talk about when it comes to recommendations or something. But unless we are having high quality randomized control studies and systematic reviews, meta-analysis of randomized control studies, we're not talking here about a very good evidence or strong, at least, evidence to support our decisions or recommendations. So again, the steps of practicing evidence-based medicine, we need to ask a focused question, track down the evidence, critically appraise evidence for validity, effect size, precision, apply the evidence in practice, amalgamate the valid evidence with other relevant informations, implement the decision in practice. Of course, each step of those, it's not as easy as we are just mentioning now. It's a long journey, and this is exactly what people are doing when developing guidelines. And but I'm just trying to tell you, this is not a short story in order to come up with evidence that can change your practice. I will, as I said, I will have a short, quick exercise just to show how can we critique quickly an interventional study. And this is a study published back in 2010. I'm familiar with the study because, and I think Dr. Yasin, his group, was part of this PROTECT trial before, but I wasn't doing my fellowship at McMaster when they did this. So what we are talking here about is the validity. When you're talking about critiquing or how to read a study, we're talking about how valid is the study. So we're talking about external and internal validity, results, and applicability. These are three important points that we need to highlight. So first thing is this study addressing a clear Pico question. The Pico format is very important because it simply make it more easy for people to understand. So, and you can see most of the clinical trial published in the big journal, it's very short title. It's exactly what they need to know. So population, intervention, conversion, and outcome. So here's the population of this study, the critically ill medical surgical adult patient who expected to remain in the ICU for at least 3 days. Interventions, in this study, they tried to investigate one of the low molecular heparin, deltaverin, at a dose of 5,000 units once daily. And the conversion was the unfractionated heparin. So simply they want to know which is better, the low molecular weight heparin or the unfractionated weight heparin. And the outcomes are the proximal DVTs, incidence of proximal leg DVTs defined as a new thrombosis detected 3 or more days after randomization, and lots of secondary outcomes, including the PEs, the venous thromboembolism, the death, of course, the bleeding and HET. So, and there is a list. This is the list that we usually teach our residents and in order to present it during their journal club. So very important to look at answers of those questions.
Allahu Akbar, we will kill you all. Fuck, bitch, you are fucking piece of shit. I will kill Mohammed bin Salman. Fuck, fuck you, bitch. I will kill you, everyone. I will.
I think we don't need to admit anyone. If you can just
I think so. Should not admit.
Okay,
anyone.
doctor. Noted, doctor. Noted.
Don't admit anyone anymore. Okay.
Okay, thank you. Okay.
Okay. Here we're talking about the checklist that everyone should go through in order to critique. Here we're talking about interventional studies, and it's simple and easy, but you need to know how can we find the answer for those questions. And this is what I'll try quickly to illustrate in the next few slides. So for example, we need to know what's the difference between validity and reliability. So the validity is how accurate. So the degree to which what was measured correspond to what really the target of interest. And also reliability is a precision. Repeated measures yield most similar findings, random error related to poor reliability. And I will show you how this can be interpreted during the evidence. So is the evidence is valid? Is it important? And does the evidence apply to our patients? This is the most important question that we need to answer during reading an articles. So for example, one of the validity question and one of the easiest question to ask is the assignment of patient. Were those assignment to treatment were randomized? So we know that clinical randomized control trial is the best way of sampling techniques, let us say. So everyone has the chance to be in either groups. There are lots of ways to do this, but the most acceptable and almost accurate one is the electronic approach. And here is in the study, there was a search pharmacist randomly assigning patient to receive either subcutaneous deltaverin or unfractionated heparin. Of course, this is a blinded. How can you find this? You will find this by looking at the study method. Clearly, they will show you or tell you how did they do their randomization. Okay. Other ways doing this is envelopes, telephone generated, or computer generated, the most commonly used one. Okay. Concealment is another important thing to look at in the methodology section. We need to know if this randomization was concealed in order to avoid influencing on group assignments. So basically, the person randomizing subject cannot see which assignment is about to be made. Also, it's an extra step to do to minimize the bias of randomization. I don't know if I have a good-looking patient that's healthy. I don't want him to go to my intervention arm in order to get a good results. So this is simply what does it mean? Another important thing that we need to look at is where all patients who entered the trial probably account for and attribute to its conclusion. Usually the flow chart in the trial can tell you if most of those patients or all of those patients completed the trial or not, or if there is any missing follow-up. Let me give you a short example of why this is important, because if 100 patients enrolled and over time 30 of them lost follow-up, so we don't know what happened to them. 10 patients died. Simply you're talking about 70 patients at the end. They reached the end of the study because 30 lost. So if we say event rate, I can say that 10 died out of 100, 10%, but who knows? It could be 40. Maybe the 30 that lost follow-up also died. So it could be 40%. So this is how important it is to look at the missing follow-up, because this might completely changing the results and affect the result. Because the follow-up rate here is more than 70%. Usually in the randomized control trial, we don't see this big lost follow-up, but something just to make it clear how this is important. So how do they overcome this? It's by intention to treat analysis. I'm sure most of you heard about it. So where patient analyzed in the groups to which they were randomized. So regardless of those patient lost follow-up, if they are randomized to the intervention or to the control group, they should be analyzed in the same group. And this is kind of a very conservative approach, and we're assuming that they have the bad outcome. So very conservative approach not to, so the results cannot be, and some people, in order to do it, they do intention to treat, and also they do per protocol. So they do both, and they report both. So intention to treat, including everyone, even those who lost follow-up; per protocol only, including people who underwent the interventions only, or the placebo or the control. So intention to treat, again, all patients allocated to one arm of RCT are analyzed in that arm, whether or not they completed the prescribed treatment or regimen. Okay, so simple illustration here: 100 patients, 30 drop out, 70 reach the end of the trial, 30 cured. How the intention to treat will deal with this? Cure can be 30 out of 70, but in the this is here the intention is the 30 out of 100. So they assumed that they completed the analysis, and everyone is included in the final analysis. So we have to be familiar with the term efficacy. So a measure of benefit resulting from the intervention for a given health problem under the ideal conditions. This is usually what happens during clinical trials. Effectiveness is a measure of the benefit resulting from an intervention for a given health problem under usual condition of clinical care for a particular group. So few terms just to be familiar with. Another principle that we need to look at during assessing clinical trials is the blinding. So there is single blinding, double blinding, triple blinding. So simply single blinding when the participant is not aware whether he or she belong to a case or control group. Double blinding, then the doctor participant. Triple blinding, some participant, doctors, and the person analyzing the data are not aware of the interventions. But sometimes you cannot blind of the intervention. For example, if I would randomize people to do a surgical procedure versus not, how can you? There is no way of blinding here, or diagnostic test, for example, CT versus not, ultrasound versus not. How this can be overcome during they will tell you in the methodology section that the outcome assessors are blinded. So the people reading the reports or reading the images or reading the pathology section out of the surgery, they're blinded. They don't know which patient is this. So by this, they are trying to minimize the risk of not being blinded study somehow, but other interventions, of course, co-intervention cannot. And simply, you will find this clearly written in the method section. So you have to be aware, and you have to report this during your presentation, or if you are discussing this paper with people. Table 1 usually in any study will tell you the baseline characteristics and how balanced or prognostically balanced are both arms. And it's simple. You can just look simply. They don't report p-values now, especially in the New England. But simply you can tell that most of the randomization, this is the aim of randomization, actually, to make both groups balanced. So you look at things here and tell me that, okay, this is a very well balanced, very well randomized study. Co-interventions, of course, is very important. If there is anything can be given, it should be reported during those studies. For example, in the study, they reported other interventions like prophylaxis, aspirin, statins, mechanical prophylaxis. Anything might affect or contaminate the study interventions need to be reported. And usually, if there is a good randomization, you will find those are also well balanced. After that, we'll go to the results, and this is a very important, and most of the editors, they look at to the results are the very important, influencing of course the study method, but I'm here talking about how the magnitude of effect. If there is a very good positive result, or even negative sometimes, to stop some intervention that might not be needed. Different measures have been reported. You might be familiar: relative risk reductions, absolute risk reduction, number need to treat, confidence intervals. I'm just listing those just to, I'm sure most of you are familiar with this, but I need to make sure that they really know what is it. Why this is important? let me give you this example, interpreting the evidence. If you are a billionaire and willing to fund a mammography screening, so there are many people come to you, they want this fund, and program A or Institute A, they told you they told you that they have a program that you need you to fund that will reduce the rate of death from breast cancer by 34%. Program B, they said that out of 1,500 women needed to be screened yearly for 7 years to prevent 1 death from breast cancer. Program C said, okay, no, our program will increases the rate of patients not dying from breast cancer from 99.82 to 99.88%. So I'm sure if I'll ask any one of you which program will choose, it's clearly here that program A is having a very good number, that they will reduce the death by 34%, while if you look here, okay, over 7 years and only prevent 1 death, doesn't worth it. The last one is from 99.8 to 99.88, also doesn't worth the efforts. So this is how they present their proposal. But guess what? All those programs are the same. It's almost the same result. But the difference is only the first one reported as a relative risk reduction. The second one, the absolute risk reduction. And this is why it's important to understand that this is not the time to explain exactly how this works, but simply if I will tell you the relative risk of the intervention to decrease this outcome or this outcome is like 0.3 and very narrow confidence interval. I'm talking here about 1 minus 0.3, so 70% relative risk reduction. This is how relative risk can be interpreted. But simply, my message here is to tell you, you need to be very careful and or very familiar with understanding those measures in order to interpret the results and to know if this is really important outcome or people, because you know what, like there are many examples I can tell in my mind now. Personally, we like to see the absolute risk reduction. If people tells you that the mortality before the intervention is 30%, and after the intervention become like 20%, like 9% absolute risk reduction. This is really important. But if I tell you that the intervention, before the intervention, the mortality was 2%, and after the interventions become 1%, it's only 1% decrease. But the relative risk here, the reduction is 50%. So this is how inflation, and that's why relative risk reduction usually inflate results, while absolute risk reduction can tell you the true results. I mean, the true magnitude of the measures. I will not go through this exercise because this is just, I'm trying to teach how to calculate this, but I think time will not allow, but simply we will calculate the event rate in each arm, and out of those, we can calculate the relative risk and the absolute risk. So we'll try to just, I try to use a very small numbers. This is, of course, this is like not a real data. I'm talking about if I give aspirin or placebo in 10 patients, and the first group, the aspirin 3 died, and the placebo group 7 died. The relative risk, simply you calculate the event rate in the experimental group by dividing the 3/10 over the 7/10 in the placebo group, and you will end up having the relative risk. And of course, to calculate the relative risk reduction, it's 1 minus the 0.42, 0.58, which is 58% relative risk reduction. The absolute risk is quite straightforward. Simply, you will subtract the event rate in the control group from the event rate in the intervention group. You will end up having the absolute risk reduction. Number to treat, you need to divide 1 by the absolute risk reduction. So 2.5, it means this intervention can say I need to give it to 2.5 people in order to save one life, something like this. So as this is a intervention, this is the last question I need to ask when it comes to reading any paper. This can be applied to my patient care. Patient similar for demographic, severity, comorbidities, other prognostic factors. You decide. You think if this is a very applicable, you think, because sometimes, you know what, they included patient with very restricted like inclusion criteria and very wide exclusion criteria. And you come at the end and say, okay, but this is not exactly my patient. I'm interested to know more sick people, to see more sick people involved or enrolled in this trial, for example. For example, the critical care, we need to see how sick patients can benefit out from those interventions. And sometimes the clinical important outcome is involved. So, you know, the surrogates outcome sometimes is very fancy, and you find, okay, the echo results later on become improved, the CT, the imaging, some lab tests, but at the end, there is no clinically important outcome different. So this is very important to look at. We need to know if this is just like a joke, if he died with a normal A1C. So just like telling people that some surrogate outcome, they don't really correlate with the clinical outcome. Are the likely treatment benefits worth the potential harm and cost? Is very important. If there is a very costly and affordable intervention, this is something we need to take in consideration. Yes, we know this did work, but we cannot afford it to our patient. And of course, you need to look at the adverse events of those intervention. Number need to harm sometimes. So what's coming? Now let's pause here. And now I talked about a lot about evidence-based and how can we come up with a conclusion of clinical trials in order to apply this to our practice, in order to prevent any misleading advertisements, outdated kind of science, but nothing perfect. Even evidence-based medicine carries its own drawbacks, and there are a lot of critique when it comes to, okay, but usually we're talking about very ideal situations, generalizability, something applicable, for example, in Australia, those kind of races or people, they might not be applicable to my patients. So here in our region, for whatever or unknown reasons. And that's why the principle of personalized medicine now is coming. And I'm sure some of you heard about this. Barack Obama, the US president in 2015, was telling that doctors have always recognized that every patient is unique. And doctors have always tried to tailor their treatments as best they can to individuals. You can match a blood transfusion to a blood type. That was an important discovery. What if matching a cancer cure to our genetic code was just as easy as standard? So what is fighting out the light dose of medicine was as simple as taking our temperature. So here is talking about personalized and individualized treatment interventions. So personalized medicine, simply this new thing coming. It's not really very new. People talking about this for many years now. It's a form of medicine that uses information about person's genes, proteins, environment to prevent, diagnose, and treat diseases. And I'm sure most of you heard about this huge discovery, I think 2 months ago, the complete sequence of a human genome. Those guys working in genetic science, they find the complete gapless sequence of human genome. So for us as a clinical or healthcare provider, how this is important, medical implication or proposed medical implication of complete genome sequences. This might provide information on genetic variants that can lead to disease or can increase the risk of disease development, even asymptomatic people. So it's like kind of early detection. Also, it can increase the ability to act primitively prior to disease development or commence treatment for disease that has not yet been diagnosed. Also, the DNA or genome sequencing can provide a precise diagnosis, which might affect the medical management of symptoms or provide treatment options. Also, drug efficacy, adverse effect, and some people also talking about drug resistance, why some people responding, some others are not responding. So it's a very important medical implication might be now solved with this. Other different target groups that can benefit from DNA sequences can be divided as follows. Those presumed healthy individual for proactive screening, like a family member who's having cancer, what's the potential that other people in the family, they might have the same, so early detection. Pregnant women for fetus development screening, cancer patient for treatment option, people with undiagnosed condition for potential disease diagnosis. So what I'm trying to say here, this is something that we still we're not really having a lot of information about, but it's really promising, and people are talking this is a huge database discovery for many years now. Let's hope this will help in targeting our treatment and interventions and all, I mean, clinical practices, not necessarily the critical care. So by this, I think was my last slide. Yes, this was my last slide. So thank you, everyone. And I would like to thank Dr. Prof. Yassin and the group for organizing this event and keep doing such a great event under the umbrella of scientific medicine. It was a pleasure being with you this evening. Thank you.
Thank you, Prof. Muhammad, for this excellent presentation. Very insightful, and I learned a lot. It's really fantastic. So we'll open it for questions, and so if for people who have questions can raise hands, and then we'll unmute. I think there's a question already. Dr. Fadi Jamal. Dr. Fadi, تفضل.
السلام عليكم ورحمة الله.
السلام ورحمة الله وبركاته.
Thank you, Dr. Muhammad, for this condensed, I would say, course about the RCTs. So appreciate it for what you have mentioned. I need to mention just a few comments about a couple of issues related to the evidence-based medicine. I like the quotation which you mentioned in the beginning about that who doesn't know how to read a paper, that he's almost equivalent to somebody who cannot perform the cardiovascular examination. Because honestly, I noticed that especially from the juniors, somebody who would come to you coming with the conclusion of the paper. Let's say like he comes from about the paper of certain intervention, like some of them, especially with the COVID era, somebody will run to me in the round about using colchicine or hydroxychloroquine about the management of the COVID. So I appreciate what you mentioned about the methodology of the paper, because rarely we go, or especially the juniors, they go through the methodology of the paper. And especially the medical reps, also what we noticed, especially for somebody who covers clinics, the medical rep, he will fascinate you about the result of the paper without going to the methodology. And it is very important for the validity of the results that the methodology is well done. This is one point. The other point is regarding the RCT versus the observational. Honestly, I think that the RCT is the pinkish or the best scenario, I would say, best scenario for an intervention. Unfortunately, for the RCT, usually they choose the best scenario and the patients who are the best to give you the best results for the intervention. And when you go for the real life and when you apply it for your patient, يعني زي ما تقول يعني تجيك مفصله ابدا، يعني لازم تجيب المريض اللي مفصل على هذا الار سي تي. But when you want to look for the patient who really fulfills the criteria of the RCT, you have to look between your patients for somebody who fulfills the criteria of the RCT. So that's why we are unfair for the observational studies. The observational studies ياخذ لك المتردية والنطيحة، ياخذ لك يعني patients inclusion criteria تكون more redundant compared to the RCTs, and that's why even if you go to the literature, you found the literature of the observational study, it is much bigger than the picture of the RCT. And it does not mean that this is an observation study that the evidence is necessarily weaker than the evidence from the RCT. So we are almost unfair to the observation study compared to the RCT. And the RCT is usually done under very controlled situations and the best scenario for an intervention. النقطة الثانية هي موضوع some of the RCTs they play about the combined endpoint, and this is sometimes it's dangerous. يعني يجي يقول لك مثلا إنه I would say mortality مثلا أو plus discharge from the ICU. With this, sometimes if you are not really picky or expert, you will not notice that the endpoint or objective, it was driven by this rather than this. I think those couple of points which I might add to your very valuable presentation. And thank you very much.
يعطيك العافية دكتور فادي. Thank you so much. Very important and very valid comment. I think we all in agreement that it's a very important skill to teach ourselves and our juniors how to critique an articles and how to know. And of course, evidence-based medicine, nothing perfect. There are, like what you mentioned, some trials very restricted inclusion, exclusion criteria, not really applicable to my patients. So, and again, this is something you only can identify if you know how to read papers and you become familiar with this. So yes, and this is like what I say, effectiveness and efficacy. We know that clinical trials is the ideal situation of managing patient. Everything is controlled, but in reality, we need more pragmatic approach, pragmatic studies. But the only thing that I might be careful is that observational studies, applying results of observational studies, it carries a huge risk of bias. Of course, there are very good observational studies, and definitely some intervention you cannot, run a trial. So we're only left with observation study, but at least we know there is some controlling for confounders and sample size. Many important factors play a role in order to accept at least those kind of results. And even when you recommend or using those studies, you will use with cautions, with conditional recommendations. It's again, it has its own path. So thank you, Dr. Fadi. If you have any other comments or questions.
Any other questions from the audience? I have a question for you, Muhammad. I think this really you highlighted the importance of the patient value and preferences in the decision making, which is really super important. And I know you are working on multiple clinical practice guidelines. How much we are able so far to get the patient engaged in the guideline process. We try to do this. It has some. It's not that easy. But what's your perspective on getting residents? Getting the patients and families, and practically, I think this is important for the near future. How can we go about it?
Definitely, yeah. So so you asked me about personal experience. We had an experience twice. When actually when we're reaching almost. So I think Dr. Omar was with us this evening or not, but we're working on guidelines on VT prophylaxis on trauma patients. Because this is a topic that we felt it's really understudied, and there was almost 12 Pico questions, and the work has been, and you're with us, Dr. Yassin, in this over the last 1 year, and we've been able to recruit a patient representative in this guidelines. This patient, basically, he was a victim of a motor vehicle collision. And because personally I know him, he was in my unit for like few months, after the trauma, head injury, multiple traumas. And I know he's good in, in English. So there are a few criteria that we've been lucky to find him, and he was very cooperative, and we find him that he's really interested and want to be involved. We conducted a couple of meetings with him. So basically, when we end up having the evidence grade evidence synthesis, we sit with him, me, Marwa, and Walid, and we talk to him how about the Pico, what we are aiming to, what our recommendations we are looking, what recommendation we are looking for, what interventions, and we discussed this with him. Let me say the simplest way possible to let him understand when we were talking about the desired effect, the undesired effect, how this, and we are listing the numbers to him and explaining the magnitude of the effect size here. And we found it really very interesting, and he was really engaged. And we don't, personally, I was thinking it will be very difficult for him, but luckily he was very familiar. When we are going with time, I think next week we're also having a meeting with him. We're almost finishing like 9 or 10 questions. He's very engaged. He got involved with us heavily in the recommendation. We did not try to influence his decision, and almost always his decision was, or let me say, an agreement with the recommendation have been done by the panel. Just to shortly answer your question, yes, I had one experience and it was successful. But I think identifying the right patient representative is very important. I would think it's something that we can do, and you know this also better than me, that to add a lot to the guidelines, having a patient representative perspective, and this is what we tried to do during our last experience. I hope I answered your questions, Saeed.
Very well, yeah. Thank you very much, Dr. Muhammad. Any other questions from the audience? If not, I really like to thank you on behalf of the all my colleagues and on behalf of the Saudi Critical Care Trials Group and the Guidelines chapter as well for this outstanding presentation. And thank everybody for his time tonight.
Thank you. Pleasure is mine, Abu Saeed, and thank you everyone for your attendance and listening to it. Thank you.
Take on laughing. Have a good night. Bye-bye.